Welcome to session 43 of the Falcon Physician Review Series. This is the online anatomy component, and we're going to be discussing the Pterygopalatine fossa. Now, the Pterygopalatine fossa can be a very complicated and small place if you don't understand what's supposed to be going on there. Let's start out this session by thinking about how it could tie into some USMLE type questions. And let's have a 14-year-old patient that's admitted to the hospital to remove an asymptomatic but fast-growing tumor from the Pterygopalatine fossa. It was noted upon imaging for an unrelated head trauma. If the tumor is allowed to continue to grow, which of the following symptoms would be the most likely to develop? This question is asking whether or not you understand what's going on in the Pterygopalatine fossa and how small this space is. Now, which of the following functions contains modalities that are distributed through the Pterygopalatine fossa is essentially all it's asking you. So, what are the options? Hopefully, you're cluing in on the fact that the corneal ulceration is the possibility that could come from a tumor growing in the Pterygopalatine fossa. This is kind of an indirect component of getting to the answer, though, because what's going to be happening is you're going to lose lacrimation to the lacrimal gland, and after you lose lacrimation, there's an increased risk of corneal ulceration. Sensation to the auricle is provided from the infratemporal fossa and from the cervical plexus. The difficulty chewing is going to be associated with motor cranial nerves, and those are going to be associated with V3 because those muscles of mastication. Difficulty swallowing is going to be pharynx and tongue associated. And then sensory loss to the anterior two-thirds of the tongue is cranial nerve 7 associated. And that's below the corner of the mouth, so it would have to be V3 and 7. So where is the Pterygopalatine fossa? Well, what we have is the concept of the grand central station of the midface. Now, it's certainly not grand, it's quite small, but it really is an inverted pyramid-shaped space which is sitting behind the maxilla and in front of the pterygoid plates of the sphenoid bone. And you can almost see through it with this little triangular inverted pyramid that you can see in the lateral wall. If you look through that area, you would be looking into the Pterygopalatine fossa. So what's the purpose of the Pterygopalatine fossa? Well, it's an opportunity to bring in blood supply, general sensation, and autonomics, and then mix them together and send them to various distribution areas all as one unit. Let's look at how it's organized. First of all, this inverted pyramid has a posterior area which is made up of pterygoid plates. Anteriorly is the maxillary sinus. Superiorly, there's the orbit. Inferiorly is the oral cavity. And medially and laterally, we're going to have the nasal cavity medial, and the lateral will be the infratemporal fossa. So it sits behind a lot of major areas. Therefore, it can distribute to or accept things from any one of these areas. Let's put it together to give a better sense of what's happening. Here, you can bring in a roof, which would be the floor of the orbit. You can bring in a posterior wall, which would be the sphenoid bone of the pterygoid plate. Then you can bring in an anterior wall, which would be the maxilla. And you can bring in a lateral window, which is an open crack, so that's going to be the pterygomaxillary fissure. Finally, we can put in our exit points, which would be one up into the orbit, one into the medial wall of the nasal cavity, and one into the floor towards the palate. So we're going to have 3 entrances as well. Those are all in green. That's going to be bringing in blood supply through the pterygomaxillary fissure, autonomics through the pterygoid canal, and general sensation through foramen rotundum, which is going to be V2. Then you're going to have 3 primary exits where all 3 of these things leave together through the pink exits. It's going to get to the midface and the lacrimal gland by going up through the orbit and into the infraorbital groove infraorbital canal and then out onto the midface of the infraorbital foramen. It will drop medially into the nasal cavity through the sphenopalatine foramen, and then it will drop inferiorly into the palate through the palatine canal. So what do we have going on in separation here? Three modalities coming in separately from three different regions. From the pterygomaxillary fissure and the infratemporal fossa, we have the maxillary artery. That's going to bring in blood supply. From the pterygoid canal, we're going to bring in both parasympathetics, which is the pterygoid canal, nerve of the pterygoid canal, and that's going to be greater petrosal, and then sympathetics from the deep petrosal nerve off of the carotid plexus. Finally, the third thing we need to bring in is general sensation, which is coming in with V2 from the trigeminal ganglia. As it exits, all of these three modalities, blood, autonomics, and general sensation, have mixed together, and they will go to the regions out from this grand central station of the midface. If it goes into the orbit, it's got to go up through the roof, and it's going to become portions of the infraorbital nerve, the infraorbital artery, and parasympathetics that will jump up and communicate to the lacrimal gland. Secondly, there's the sphenopalatine foramen, which will allow the sphenopalatine artery, the nasopalatine nerve, and the autonomics, which will keep the nasal cavity wet, all going through and into the nasal cavity. And then finally, there'll be a branch that is dropping down into the palatine canal, which will include the descending palatine artery, the greater and lesser palatine nerves, and general sensation to the palate, as well as the autonomics that